In normal times, conventional care, a doctor's fiduciary duty is to the patient in front of them. You do not take a ventilator away from grandma to give it to a younger person. That would be abandonment. But in a declared crisis, the ethical framework flips. We pivot to utilitarianism. The goal becomes population survival. The duty is to the community. This shift is so radical that it usually requires a legal declaration of emergency by a governor to protect doctors from liability. We are moving from a deontological framework, duties, rights, to a consequentialist one, outcomes. The primary goal is to maximize benefits. But what does that mean? Does it mean saving the most asterisk lives asterisk, head count? Or saving the most asterisk life years asterisk? If we save a 90-year-old, we save one life. If we save a 20-year-old, we save one life asterisk, and asterisk 60 potential years. Most crisis protocols aim for a mix, but they lean toward life years. There is also the concept of instrumental value. This suggests we should prioritize saving the savers, doctors, nurses, respiratory therapists, not because they are better people, but because if they die, the whole system collapses and everyone else dies. Reciprocity implies we owe them priority for taking the risk. How do we operationalize this? We don't want doctors guessing. We use scoring systems. The most common is the SOFA score, sequential organ failure assessment. It measures the function of lungs, liver, kidneys, etc. It predicts the likelihood of death. In a crisis, you calculate the SOFA score for everyone. The patient with the lowest asterisk score, meaning the best prognosis, gets the ventilator. The patient with a high score, meaning they are likely to die even with the ventilator, is triaged to palliative care. We are not abandoning the dying. We are refusing to waste a scarce resource on a futile case when it could save a viable one. What if two patients have the same SOFA score? How do we break the tie? This is controversial. Some protocols use age as a tiebreaker, prioritizing the younger patient based on the fair innings argument. The young haven't had the opportunity to live a full life yet. Others reject age as discrimination and prefer a lottery, random selection. Almost all ethicists agree that first come, first served is unethical in a crisis. Why? Because it privileges those who live closer to the hospital, have better transportation, or got sick earlier. It creates a rush on the bank mentality. Random lottery is fairer than a foot race. During COVID, a massive debate erupted over equity. We know that minority populations have higher rates of comorbidities like diabetes, hypertension, and kidney disease due to structural racism and social determinants. If our triage protocol relies solely on organ function, SOFA, it will disproportionately screen out Black and brown patients. We are effectively baking racism into our lifeboat rules. We are prioritizing the white and wealthy who have had better access to care. To correct this, some bioethicists proposed adding an equity weight, giving a boost to patients from disadvantaged zip codes using the Area Deprivation Index to level the playing field. Disability rights advocates also fought back. Early protocols in some states excluded people with severe cognitive impairment from ventilators. The HHS Office of Civil Rights stepped in and declared this illegal. They ruled that you cannot categorically exclude people based on disability or long-term life expectancy. Triage must focus only on short-term survival. Will this patient survive this infection? You cannot judge the worth of their life. This forced hospitals to rewrite their plans to be disability neutral, removing quality of life judgments from the triage officer's toolkit. The hardest part of crisis standards is reallocation. This means taking a ventilator away from a patient who is already on it, but not improving, to give it to a new patient who has a better chance. This feels like killing patient A to save patient B. But ethically, in a crisis, possession is not 9/10 of the law. The ventilator belongs to the community, not the patient. If it is not working for patient A, we have a duty to steward it. However, the psychological trauma of extubating a living person is immense. Many hospitals refuse to do it, choosing to just close the door to new patients instead.
To protect the staff, we use triage officers. This is a separate doctor who does not care for the patient directly. They sit in a room with the data. They decide who gets the vent. The bedside team's job is just to advocate for their patient. This separation of roles is crucial. It allows the bedside doctor to tell the family, "I did everything I could, but the triage committee made the decision." It deflects the moral burden and preserves the doctor-patient relationship. It creates a buffer against moral injury.
As we conclude Module 5, understand this. There is no perfect system for rationing. Every choice leaves a scar. The libertarian leaves the poor behind. The utilitarian sacrifices the disabled. The egalitarian might bankrupt the system. The lottery feels arbitrary. The only wrong answer is to pretend we aren't choosing. We must face these choices with transparency, using the best ethical frameworks we have. Next week, in Module 6, we will explore the biopolitics of reproduction, abortion, eugenics, and the control of populations. It is another heavy week, so take time to digest what we've covered. Thank you. I leave you with this reflection. If you were behind Rawls's veil of ignorance, not knowing if you would be the young person needing the vent or the elderly person losing it, what rules would you write? That is the question that defines civilized society. I'll see you in Module 6.